very good morning and a warm welcome to the CNBC Africa special brought to you in collaboration with GE Healthcare. We're coming to you live from the city of Cape Town where the 25th World Economic Forum on Africa is currently underway. Now, the reason for our gathering this morning is to look at how we can bridge the gap between providing sustainable and efficient healthcare, not only in the primary healthcare center, but also when it comes to a focus on maternal healthcare and moving from the MDGs 4 and 5 and finding sustainable solutions to these developments. Now, as you can tell, because this is a live broadcast, we do come to you from the wonderful city of Cape Town, and we have a vibrant audience that will be participating in our discussion today, but also an esteemed guest of panelists who will be giving us their insights as well as workable solutions as to how we can move forward when it comes to healthcare. I'd like to welcome, firstly, the Honourable Minister of Healthcare in South Africa, Dr Aaron Motsoaledi. We've got Mr. Skander Malcolm, President and CEO of GE Healthcare Eastern and African Growth Markets Region. Dr. Godfrey Mbaruku, Deputy Director of Ifakara Health Institute in Tanzania, and Haddis Taddesse, the country representative of the Bill and Melinda Gates Foundation from Ethiopia. Not only that, but we do have a guest with us in Johannesburg, Dr. Sarah Barber. She's the country representative from South Africa for the World Health Organization, joining us from our studios in Johannesburg. And we'll also be hearing insights from one of our other panelists who sat down with one of our reporters in Abuja earlier on this week to get her insights. That's Dr. Nenna Ihebuzor, who's the Director of PHC Systems Development, National Primary Healthcare Development Agency in Nigeria. More importantly, you are also able to take part in this conversation today by joining us on social media networks and using the hashtag Health in Africa 15, hashtag Health in Africa 15, and participate with us as we tackle this program. Well, in the first 28 minutes, we'll definitely be focusing on primary healthcare and what is necessary for us to continue in this regard. And let's start from a local perspective, where we've got the Minister of Health with us. And if you can maybe give us a quick overview, Minister, as to when primary healthcare was mainstreamed into public clinic facilities in South Africa back in 1994. Have we managed to progress efficiently since then?
Well, maybe we should start by having a common understanding of what primary health care means, because sometimes it means different things to different people. In our understanding here, primary health care means a healthcare system whereby prevention of diseases and promotion of health is at the center, and whereby entry to the healthcare system starts at the bottom, not the other way around. That means you don't start at tertiary hospitals, you start at the clinic level, going upwards in the continuum of referral. Now, we did declare as early as 1994 that the healthcare system in South Africa will be based on primary healthcare. But lots of factors intervene such that many of the things that we should have done did not happen. Why? Because I think the whole world now, except a few countries like you, we are absorbed by what the World Health Organization in the 2008 report called a hospice-centric system. What Dr. Margaret Chan, the Director General, in 2012 said, we are seized with curative healthcare system that leaves prevention by the wayside. So we are also victims of that. We're talking about the whole world. Now, we are trying our best to go back. You are aware that we are moving towards universal health coverage. In South Africa, we call that NHI. In the policy document, we are putting it clearly that primary health care is going to be the heartbeat of the healthcare system. And everything we are planning around primary health care, meaning prevention of diseases, promotion of health, and starting the health care right at the lower level, right, even before you arrive at the clinic. That is why we are in the process of training and appointing 40,000 as a minimum starting point of primary health care workers, which will be in all municipality wards, in our villages, and in our townships, and even in cities. Lots of primary health care workers. In our national development plan, they were actually meeting that we must have 1 million primary health care workers by 2030.
Is it possible?
Well, yes, exactly. We said that's a big dream, but let's, yeah. And then they went out to 700,000. I know by now that India has got 800,000, but with their huge population, we can't be moving in that direction in South Africa. But I know that Brazil has been able to make a huge difference with 30,000. So our starting point is 40,000. And at the moment, I think we have trained between 5,000 and 6,000 of such primary healthcare workers. And it's something that is going to continue. That is our starting point.
Mm-hmm. Mr. Malcolm, maybe if you can give us further perspective, as the Minister says, the understanding of primary healthcare, but why is it such an important area that we need to focus on to enable not only the cultivation of economic growth across African continents, but also to find human development there?
Sure. I mean, the Minister is absolutely right. Primary healthcare, when it's done well, is at the heart of every very strong healthcare system and sustainable healthcare systems. And there's absolutely no reason why Africa can't have a strong and sustainable healthcare system. It's been proven and published that, for example, strong primary and referral care networks can reduce infant mortality rates by up to 20% and post-neonatal deaths by up to 40%. Furthermore, in Africa, what we're seeing now is, unfortunately, a huge rise in non-communicable diseases. It's up about 30% in the last 10 years. What primary and referral care does is it, particularly in the communities, creates great programs of prevention and early diagnosis that can then be referred and treated or prevented, which drives huge economic benefit and, as you said, social prosperity.
Mm-hmm. To come to both our representatives, firstly, let's get the Tanzanian view from Mr. Mbaruku, Dr. Mbaruku, who can give us the view as to the operations on the ground. Clearly, this needs some kind of infrastructural development to support the primary healthcare system, not only in Tanzania, but across the globe.
Yeah, as my colleagues have said, primary healthcare is the cornerstone of healthcare in Africa. And as long as we concentrate on primary healthcare, we will be able to address the major issues of the major problems of our people in our countries in Africa. Because if we depend on curative services or hospitals, whereby 70 or 80% of the people live in the rural areas, then it's a bridge too far. So it's better to concentrate on primary health care so that many more people benefit from the issues of getting the appropriate health care to the population.
Mr. Taddesse, maybe if you can also come in with your view as to what kind of developments you've been seeing on the ground in Ethiopia at the moment before we tackle the sustainability of moving forward going.
Sure. Thanks, and great to be here. So the Gates Foundation was actually created on the premise that all lives, no matter where they're being led, have equal value. And particularly the health of women and children is central to that strategy for the foundation, so we've done quite a bit. Ethiopia is a very interesting case, and there are very similarities to what the Honorable Minister mentioned in terms of the primary healthcare services. About 10 years after South Africa, in 2004, Ethiopia deployed a very robust health extension platform, really recruiting and training 40,000 women, exclusively women, health workers to go to every village in the country. And the work that they've done has been really remarkable. They have 16 packages, mostly preventative, that they're responsible for. They split their time between the health post and visiting homes, particularly around pregnant women. And the health post, which is the lowest level of administration, is a catchment area for about 5,000 people. And then there's a second level, which is a health center, which is for about 25,000 people, and then a primary hospital. This really constitutes the primary healthcare services in the country. And then you have a general and specialized hospitals. The impact of that has been phenomenal. You have seen a 67% reduction in child mortality in the country. Maternal mortality has gone down significantly. Rate of immunization has gone up. HIV rates, HIV infection rates went down by something like 90% over a 10-year period. So these young women who've been deployed to the countryside and really work with the communities have made a tremendous progress. It's not to say it's not without challenges. There's some resource constraints. The quality of care is poor. But Ethiopia is working very hard to improve that, and the role of the private sector, I think, needs to come in and really support this platform as well. But Ethiopia has done quite well in this, and others are coming in to learn from Ethiopia.
Mm-hmm. Let's venture into what is needed, and maybe by getting an outside view looking in with Dr. Barber, who's in our Johannesburg studios. We've heard the sentiments from all our panelists down here in Cape Town telling us about the progress, what is needed to move forward. But Dr. Barber, from your perspective, what further fundamentals need to be in order? Does it start with clearly government policy and maybe the infrastructure and the capital behind it in order to work as an enabler?
Thanks very much. Yes, absolutely. WHO has something called the 6 building blocks for health systems. And these 6 building blocks are essentially the foundations for primary healthcare systems. It starts with governance and leadership, but we also need to strengthen the service delivery platforms to ensure that we have good, strong systems to ensure referrals and to ensure access at primary care level. Human resources are a critical building block. We need to invest in a strong health workforce, and particularly in primary levels and rural areas. We need to ensure we have good information systems to be able to measure progress and vital statistics systems. We need to look at the medicines and make sure that we have good systems to procure, to evaluate the quality of medicines, and to make sure that the medical products that people receive are accessible at primary care level. And we also need to look at the financing. These types of systems, particularly in remote and rural areas, do require substantial investments. And as you're mentioning, we need infrastructure investments, and we need investments in making all of this happen.
Well, let's tackle the first issue there, because clearly we need some kind of Bible which will be used as policy. Minister, we've got you here today. Are there significant changes that need to be amended in this particular Bible, if I can even refer to it as such, in order to get the capital from the private sector to flow through?
Yes, there must be a lot of... In fact, let me put it this way. It will be a terrible, terrible mistake for the world to get an impression that primary health care is for poor settings only, for poorer parts of the world, and the other richer part must do something else. It will be a terrible mistake. Primary health care is needed everywhere in every healthcare system. That's right. Yes, in September, when the United Nations moves for Sustainable Development Goals, I know one of the new goals is going to be non-communicable disease. I don't know anywhere in the world how we're going to deal with non-communicable diseases without primary health care, meaning without preventing diseases and promoting health care. But unfortunately, the world in which we are living needs an absolute change. The CEO of the International Diabetic Federation put it in this way, the world in which we are living. He said there are 3 ways of dealing with diabetes, for instance. The first and most effective is diet and healthy lifestyle. Everybody knows that. That's the first one. If that one fails, you move to the second one. You start popping pills and poking injections 3 times a day. If that fails, you start changing organs. In the world where we live, any professor who specializes with the first one is ignored. The one who changes organs is going to get the Nobel Prize. It's the best. It's expensive, extremely expensive. It doesn't guarantee any results. It doesn't bring change to the world. The first one will. But unfortunately, in the world in which we are living, it's not like that. And we need a mind shift. This is causing even poor people to start dreaming about living primary health care. And, you know, I don't want to take your time. Let me tell you, without, and I'm not saying technology is not important. I was a rural GP when the ultrasound was introduced. I saw rural women stopping antenatal care, getting the last 100 rand to go and be under a sauna just to see the sex of the baby and leave everything. No blood pressure, no test for syphilis, nothing. Just to know the sex of the baby under the ultrasound. It became a craze. And in those rural areas, primary healthcare system collapsed. Women were no longer being checked for very simple things. You know what it will do to maternal mortality and child mortality. So let's not give an impression that if you are poor, and living in an area where there are no health facilities, you move from primary health care. You will need it in the center of New York if we are going to save the world. And everybody must move in that direction.
Well, are we moving in the right direction? Dr. Mbaruku, to come to you, well, we hear the minister saying that obviously the policy needs to create this enabling environment and the experiences that you have on the ground, firstly, it seems as though we need to have a multi-pronged approach. Not only do the policies need to encourage the healthcare workers themselves to strive to enable the solutions instead of changing organs, as the minister referred to, but also for those who seek healthcare services themselves to be awakened to a new mindset shift with regard to primary health care. How do we do that, Dr. Mbaruku?
Yeah, exactly. The population, the majority of the people in Africa or in developing countries, and as the minister said, who live, most of them, we say they live in the rural areas, but we know that there's a lot of rural-urban migration. And even now, when we have people who move to the urban areas. When they move to the urban areas, they cannot access the proper health care in the urban areas itself. So they live in slums, etc. And so it is very, very important for us to understand that primary health care is important in the sense that even in the urban areas whereby most of the people live, the majority of the people who live in the slums and so on, who come from the rural areas due to this migration, they are supposed to get also the health care. But in another angle is that women themselves or men or whatever, whoever, who live in the communities, they need health as an important ingredient in their life. In their lives, and so when they fall sick, they don't have insurance, for example. They cannot afford the expensive healthcare services which are being given in the urban areas or even in the rural areas. So they know that when they get sick, then they have to get access. And how do they get access? They get access by going to the nearest clinic. When they go to the nearest clinic and you don't have the facilities there, then people suffer. So people understand and they know because this affects their lives.
Mm-hmm. You mentioned two key areas there, obviously affordability, but it almost sounds as though people need incentives to seek this primary health care. Mr. Malcolm, maybe if you can provide us with perspectives here. Do people need to be, number one, enlightened to the benefits, obviously, of accessing primary health care? And do we need some kind of incentive, though, as a motivational driver?
Well, it's very clear as well that patient awareness of conditions and how to improve, as the minister said, if you take obesity, prevention is incredibly important, and that really starts with strong lifestyle. So what we've seen is that when we run strong patient awareness campaigns in partnership with the public sector, we see a huge improvement in the adoption of primary care. They start visiting, then they actually can get into good habits, and then if there are issues that can be dealt with, they know where to actually go, and they've actually established a relationship with the clinic. So incentives are as much around just awareness of what some of the issues are. And we think the private sector can play a very, very important role here, and we have worked very closely with the public sector on a number of campaigns. In Nigeria, for example, the Save 1 Million Lives campaign, GE Healthcare was very involved in, because we could see that it created much better healthcare outcomes in the community.
Mm-hmm. Well, before we come to the audience, just to get a few questions from them as well as comments from those players in the healthcare fraternity, we're just going to get some insights now from Dr. Nenna Ihebuzor, who spoke to one of our colleagues in our Abuja bureau to get some perspective as to how they are strengthening the system in Nigeria by finding key initiatives to strengthen primary healthcare, and more importantly, how they measure the success thereof.
What Nigeria has done is it has passed, first of all, it's passed just late last year. The former president passed the National Health Act and signed it into law. And what this has done, it has provided, legal backing for all the work that is done around our health system. Nigeria's health system, it has created an enabling law for both the World Health System, the secondary, the tertiary health system. And in addition to the governance structure, what we've done is we've ensured that we have what we call primary health care under one roof. And therefore, administration and governance for primary health care is done by one body. So we don't have that segregation where primary health care is administered by both local governments and state governments. So we have supported all states. All states have been supported, but not all of them have created them. But more than 2/3 have created what we call state primary health care development agencies or boards. Measuring impact, that's really key. It's important for us in this day and age to have data for decision making. And therefore, these programs and these projects that I've talked about all have data, strengthening, built into those programs. And one of the key things that we've started is a maternal, perinatal, and death surveillance and review. Because of course, if you don't count, you can't. If you're not counted, then you don't count. So to that extent also, Nigeria is working through the Commission on Information and Accountability to strengthen its vital registration as well, so that we can be sure that every baby that is born is registered, every maternal death or perinatal death or newborn death is registered, and we can actually count, who we are and who is either being born or who is dying. And then, of course, within the local governments and within the sub-national level, Nigeria has developed a district health information system, which is the DHIS, and that is digital, and it's pushes data, data from the state level, so that Nigeria has access, to data for decision making and policy guidance.
That was Dr. Ihebuzor there giving us her perspective on what they are doing in Nigeria to help conquer the primary healthcare sector. We will delve into maternal more in depth shortly, just before the ad break, or rather after the ad break. But before we cross to an ad break, I wanted us to get a feel from some of the healthcare players who are with us in the audience by getting them to answer, or rather ask a few questions and maybe even respond with some commentary. If you do have questions, ladies and gentlemen, please do introduce yourself, tell us where you're from, and you can pose your question or comment to the panel or your fellow colleagues in the audience. Any hands? Seems as though you're all a shy bunch, which is unusual for people who work with people, especially in healthcare. Well, there's a question right here in front, so you can remain seated due to the cameras that are here in the facility, but I would like to get a quick question from you.
Yes, thank you. My name is Mike Musharia. I'm founder CEO of a company in Kenya called 76 Technologies. We team up with GE in Kenya to deliver one of what we call very most innovative solutions in primary healthcare in terms of managed services for the government, in terms of delivering healthcare across 100 hospitals, which is really in line with this conversation. My question relates to the nature of our lives in Africa. The mobile has become a critical part of our lives, right? So in terms of health innovation and mobile and triage services, why haven't we seen an adoption of mobile? Being able to offer better triage services across a country, especially in Africa, where everybody has got access to mobile. Is it the issue that there isn't anyone on the other side to be able to offer patient advice, or is it African culture that does not? You need to see a doctor. You cannot just get you cannot get any diagnosis over the phone. Any of you can answer the question.
Thank you so much for that question there, Mr. Sharia. Minister, we'll come to you in a moment. You can think about that one. Mr. Skander, let's start with you, and Mr. Taddesse, if you've got sentiments on mobile to be used as an enabler.
I mean, Mike, I'm a huge advocate that mobile can actually help us leapfrog traditional referral systems. As you know, we've participated very heavily in various trials. In Rwanda, for example, we ran an SMS campaign with the Rwandan government, which was very successful, and it was around vaccines and helping connect people in order to get their vaccines. So I think it's going to play a very, very important role. In fact, I would argue in Africa, even in the more rural parts. I was in Tanzania recently, and I get better signal there than I do New York or Istanbul. So I think it can be deployed. I think the key is let's start small. Let's create a few simple programs just to help connect people with medical practitioners. We've recently introduced technology as well that will allow, for example, images to be taken in rural settings and transmitted to hospitals and through referral networks. So I think it's going to play a very, very important role. Let's start small and let's get started.
Clearly we need to drive the demand and create awareness of this. So does that need to be cultivated by the private sector? Is it government? Is it NGOs like the ones that Mr. Taddesse is representing? Clearly there needs to be someone who will be spearheading this drive into technology and obviously using it as a facilitator. Mr. Taddesse, do you have sentiments here?
Yeah, I think I totally agree with it. It's an emerging sector and I don't think it has to be one or the other. I think it's a combination of all the players to be able to do that. Interestingly, even in the developed world, you don't see a whole lot of mobile phones being used to provide healthcare services. We need to understand why that is and see if we can deploy that in Africa. I think SMS and phone calls on mobile are actually widely used in the rural areas, either to remind women to come to the clinic or for vaccinations or whatever. So there's some mobile things that are happening, but I think we can leverage that a lot more than we are today, and I think we'll see that going forward.
Government, can it play a role?
Oh yes, we are playing a role, but I want us to be very careful because we must decide exactly where do we use it. Because I regard medicine as a form of an art, whereby, yes, health workers are a form of, they are practicing an art, and they should not easily become technicians. Yes. But there are areas where it's applicable. For instance, in South Africa, we have got what we call Mom Connect, which is making a huge difference, where we're connecting all the pregnant women on the cell phone. We have got 400,000 of them now. Every week, each one of them get a message appropriate to their level of pregnancy, what to do, what they are going to feel, what must avoid, where they must go, generally how to behave. And we do that right until delivery. After delivery, the messages switch over to the baby about exclusive breastfeeding, the importance of that, immunization, and many other issues that the baby might need. But the women also can send complaints. They can say, I went to this clinic, this. So it is able to tell us where are the problems within the system. But they also send compliments. And since we had 400,000 people, we received 300 complaints and 1,500 compliments, meaning that something good is happening. It's actually telling us what's happening to the healthcare system, but we are able to keep in touch with them. We are targeting 1 million women, and we believe we are going to reach that target. Mm-hmm. This is June. It's a youth month. We are going to launch an app for the youth. In fact, there was a competition to name it, for the young people to name it. We're going to announce it in the next 3 weeks, whereby we'll communicate with the young people. Because in the recent workshops that we have had and consultations, we are seeing a big gap of leaving the adolescents behind, whereas all the problems that we are dealing with, problems of drugs, teenage pregnancy, etc., they start right at that age. So that app is to communicate with the young people, to guide them within the healthcare system, what to do and what not to do. And there's no other way of doing it rather than using technology as such. But I'm just saying we need to choose very carefully. The last one, in South Africa, there's a big debate among doctors. Can we live whereby you don't see a health worker, you just talk to them by phone, they prescribe by phone? How safe is that type of system? That's why I'm saying we need to be very, very careful when it comes to that.
So it can be used as an assistant or enabler to a certain extent, but the personal context still needs to be there. Well, we will continue with this conversation when we return from the ad break. We'll obviously focus on some of the aspects that were touched on, especially zoning in onto maternal health care on the continent, and more importantly, the data and avenues that we need to explore in order to cultivate this environment. Stay with us. We return right after the break. Hello and a warm welcome back to the special CNBC Africa broadcast, where we're talking about bridging the gap when it comes to access to primary healthcare, and more importantly MDG 4 and 5 being the focus on maternal healthcare. And that has obviously been some of the key themes that came up in our previous discussion when we focused on primary healthcare. We heard about Mums Connect, an app being launched here in South Africa to enable a cultivating environment for mothers to connect and understand the key reasons and responsibilities that they need to undertake when they are pregnant, and also the SMSs that are being deployed in countries like Ethiopia. But Dr. Barber, to come to you in our Johannesburg studio to give us more perspective on the key focus on maternal health care on the continent. We do know that Africa has one of the highest maternal mortality rates on the continent. Have we done enough so far to conquer them, other than the initiatives that we heard in the first half of our conversation?
I think a great deal has been done. We do still have very high rates of maternal mortality in the continent, but we've also seen some of the largest reductions in the world in maternal mortality. However, I think that maternal mortality, going back to the earlier discussion, is an important indicator of the functioning of the health system as a whole, particularly access to quality delivery and labor interventions, as well as, while the primary causes are hypertension, hemorrhage, and sepsis, we also know that these conditions are aggravated by obesity, and other conditions, HIV and other infections. And so I think that it is, going back to the earlier discussion, it's an indicator that we need to really strengthen the primary care systems and the referral systems to be able to deal with these maternal mortality as well as child mortality.
Dr. Mbaruku, you've recently focused on a study looking at the experience on the ground, especially when it comes to maternal health care. The key findings, if you can walk us through that before we look at workable solutions going forward.
Yeah, well, first of all, we have to understand that the problem with maternal mortality is the measurement. And maternal death, actually, while we talk about maternal mortality as a problem, it's comparatively a rare event in the sense that you don't see people dying like flies. I want to make it very clear. But when you compare maternal mortality in Africa and also in the developing world, the difference is so huge in the sense that it's not very easy to comprehend why a woman should die during pregnancy, which is a normal event. Now, when we have one maternal death, actually the maternal morbidity, the problems which accompany maternal mortality, they are much more numerous, in the sense that for every one maternal death, you have 40 or 50 times more problems on women, like fistulas, like the other disabilities which affect women. And we have to take all that into the context. Now, after that background, I must say that recently we performed a study whereby using primary health care staff, we were able to use a simple device of diagnosis called the V-scan, which is a V-scan, which is a simple ultrasound, to be able to detect the problems early in the rural areas. Because it's very, very important to remember that maternal mortality is the lack of the continuum of care. Mm-hmm. It's not just one aspect. People talk about children's death, and they say if you give immunization, then you have less children dying, and so on. It's not like in maternal mortality. It's the whole continuum of care. So if you miss the link of the jigsaw puzzle at one point, then you have a problem. And it's the diagnosis, early diagnosis of some of these complications which occur in women, which is missed, and which causes the problem which you see at the end of the road. And so by the time the women reach referral facilities, they are in a state whereby nobody can do anything. If a woman has had eclampsia or has had convulsions or she has been bleeding for the last 24 hours and so on, but even when they reach the tertiary facilities, whereby you have all kinds of specialists or well-trained personnel, there is no way they can save the life. So it is important to understand that it's the whole continuum of care which has to be taken into account.
It almost sounds as though this goes back to the policy and framework that is established by national governments, but also needs to translate into what local government and the individuals on the ground are actually doing. Mr. Malcolm, if we come to you, before we come to government to find out if this is linking, because I do understand we've got representatives who can speak from a provincial and on-the-ground experience. From your perspective, in the markets which you operate in on the African continent, the linkages, are we finding that there are any missing loops at the moment?
Yeah, I mean, the linkages are absolutely crucial. What we found, if you take maternal and infant care, when we started to develop this handheld ultrasound technology, actually that probe was developed for cardiac use, and then we found that it had an alternative application, which actually was to help in rural settings. And why was that useful? Well, for a start, it was portable. Secondly, it was highly durable. But as we started to work in those communities, we found that there was an incredibly important linkage that was missing, and that was training. The beauty of the handheld ultrasound is that it can work in these settings, but if you don't have midwives and paraprofessionals that can be easily trained to administer the scan, then the technology is useless. And so with Ifakara, for example, we ran trials in Tanzania and Ghana, and we developed very, very simple training. We can now train a midwife or a paraprofessional in 7 days. And that has, again, if you look at the studies, that has an enormous impact on women who actually feel comfortable to go and get a scan. In Uganda, it increased the percentage of women who got a scan by 72%. And exactly as Godfrey says, if all we can do is have more women participate in the process, then we stand a much higher chance of actually scanning one of the 5 major causes of death. So that's a very, very important linkage. You must have training, and then in the community there must be good policy that allows for the community clinics to actually be able to administer this. So your point around linkage is incredibly important. It has to be technology, yes, and by the way, technology designed by the people who are administering it, the training, and then the policy and the community that can actually get involved to drive those outcomes.
Goes back to the people and the people who are interacting with these patients. Minister, your voice on the linkages is national, speaking to local, speaking to people on the ground and in the field.
Yes. Let me start here. I think we must recognize that a lot. There's been a great leap between 1990 and now on the African continent about maternal mortality. According to the recent data from the World Organization, it has reduced by a massive 48%. That's massive. But the problem is that 48% has made us to arrive not even where Europe was in 1990. We are not even there. That shows the extent of the problem. But in order to solve it, before we do those linkages, we need to understand what we are dealing with. We can't just shoot in the dark. We need to understand the causes. What kills women in pregnancy and childbirth? What is the biggest cause, and how do you intervene? Fortunately, in South Africa, we have got committees who do exactly that. We have got a national committee of inquiry, confidential committee of inquiry on maternal mortality. And they found that the main causes of death in women in pregnancy and childbirth are what we call 3 H's. They all start with an H, the top 3 causes of death. The first one is HIV/AIDS at 50%. In other words, 50% of maternal mortality is attributable to HIV and AIDS. The second one is hemorrhage, hypertension in pregnancy. And the third one is hemorrhage. All of them preventable, by the way. Yeah. Then recently we added 2 more H's, the health worker. In other words, the skills of the health worker. And then lastly, the healthcare system, whether the healthcare system is strong enough to deal with the mothers. And we're taking them one by one. For instance, for the health worker, you identified the weaknesses. We have got a system called SMOE, Essential Management of Obstetric Emergencies. Do health workers know what to do when there's an obstetric emergency? We have trained about 4,000 doctors and nurses in that system of SMOE that deals with the health worker. Do you have enough people who are trained in midwifery who understand that, you know? Then the first age, HIV and AIDS. We realized in South Africa, if we did not start our HIV AIDS programs very late, I can be telling you here and now that we're going to have no problem at all in achieving the goals of Millennium Development Goal number 5. So we have started massive programs on HIV and AIDS. That's why we've put 3 million people in South Africa on treatment. That's why we're starting PMTCT, Prevention of Mother-to-Child Transmission, at 14 weeks when we're doing it at 28 weeks. And Mom Connect is helping us to put them very early on because we know about it. Then the issue of hemorrhage and hypertension. That goes back to primary health care, which I was mentioning, the strengthening of the healthcare system. You are also aware that heads of states in Africa launched KAMA long ago, I think it's 2010, campaign on accelerated reduction in maternal and child mortality in Africa, whereby you look at all these things. For instance, if it's a problem of ambulances, do you have enough of them? If it's a problem of distance, can you get some of the mothers who are staying very far to come and stay somewhere within the hospital, you know, before delivery? We do have such systems in South Africa already. Do you have, can you have obstetric ambulances that will not go out if some drunken guy got involved in a car accident somewhere on the road? You don't let the ambulance go there specifically for the mother. You will have to find another way of dealing with that drunkard there on the road. I'm emphasizing that because it has happened, where some drunken people take off the ambulances, and while the ambulance is gone, a mother dies here. And I'm emphasizing that because it shouldn't be allowed. So can you have specifically dedicated obstetric ambulances just waiting for the mothers and babies and are used for nobody else? Those are some of the elements in KAMA that helps in this system. And it has made a change. The problem is that the Millennium Development Goals were declared in 2000, and we started these things very late, more or less a decade after the goals were declared. So the lesson being that in the Sustainable Development Goals, because we now know, we must get ready so that when the goals are declared, you start immediately. You don't wait a decade and start solving this problem, as it has happened in most parts of the continent.
Finding sustainable solutions clearly as we move forward. Mr. Taddesse, I'd like to come to you to give us your perspective from the Ethiopian view when it comes to, we've heard about skills, we've heard about the initiatives that need to be driven here, but also the cost of healthcare on the African continent does not come cheap.
Yeah. So I don't want to underestimate the complexity of this issue. Everything that we've talked about and to solve for it have to come together. Ethiopia is a very complicated country in its geography and culture. You have 93 million people very dispersed in the rural areas, about 85% in rural areas. So the hospital approach or the high-end approach doesn't really work. So you have to sort of work in the primary healthcare center. We don't have sufficient doctors. Even the doctors we have don't want to work in a very rural area. So you have to find other ways of service delivery for women, particularly in pregnancy. There aren't sufficient surgery theaters for the kind of problems that were discussed. I think policy is very, very important. The commitment of government, both in terms of policy but also resource allocation, is very important. Ethiopia has shown commitment there. If you look at the national budgets, literally 70% of the budget goes to education, health, agriculture, and roads. That's very impressive from a pro-poor perspective. But then you also have a very nomadic community, pastoralist community, which is very difficult to provide services for. So if you have women in rural areas who are 85% delivering at home, no doctors, no surgical theaters, constrained resources, not that many ambulances. So you're looking at a very massive and complicated problem. So for that to change, you have to have the right policies, more resources, the donor community needs to come together. Women have to support each other. They're model families that actually can have an influence beyond public health workers. So it is complicated, but I think over time it's a solvable problem, and I think the community is coming together to be able to do that. But I just don't want to underestimate the complexity of this issue in a rural environment like that when resources are constrained.
Sustainability is obviously what we're looking to do here and finding workable solutions. I know we have a representative of the Medical Research Council with us, Tony Bunn. Maybe if you can give us your perspectives and your view as to how we can find sustainable solutions, and something that as representatives of various African states are in the audience and on the panel today, that we can implement in the short to medium term. We'll make sure that a mic makes its way to you. You can remain seated, and we'll get your insights shortly as the microphone makes its way to you. Right in the front here, Davy. Thank you so much.
Thank you very much, gentlemen, honourable people up on the stage. Yeah, that's a very interesting question. Sustainability is clearly the word that we all want to adhere to when it comes to primary health care, and particularly maternal and child health systems. I think that the technology that we have in the world today and the technology that exists in Africa is incredibly powerful, and I'm specifically referring to the e-health opportunities and the telemedicine opportunities that do exist at this moment. My problem is, I think, that what is lagging, and there's always lag in policy and legislation, and I think these are the issues that are probably holding us back at the moment. I think Africa can leapfrog enormously because we have many greenfield situations. We're not as entrenched in systems as in the developed countries. So I think we have a great opportunity to actually leapfrog with technology. But in that regard, we need our leadership and our departments of health to actually try and motivate for improving the rate at which legislation can keep up with the advances in technology. If we can just get that in place and get the two aligned, I think we can really make substantial impact in Africa. With the new technologies, we can leapfrog like we did with cell phone technology. People never knew landlines before. Now they're all walking around with cell phones. I think that is the sort of analogy that we can do in primary health care. I think even at a lesser level, at a lower level than primary health care, even at the community health care workers, I think we need to have some triage systems in place whereby you could have tele-triage. You could have nursing sisters manning triage stations where first-time mothers, for example, who attend clinics and rush off to clinics unnecessarily, at least 50% of the time, visit clinics where they don't need to. There needs to be that added thing, post-mum connect, where they can be triaged and say, you don't need to go to the clinic now. They would normally go. Have this triage system, which is very carefully managed with manuals and clear flowchart-driven discussion with the mother to prevent them from going into the clinic. So there are all sorts of interventions that can happen using technology at this moment. I'm just appealing to our Department of Health and our Minister, let's try and get the policies and the legislations in place to enable this to happen quicker. I really believe that Africa can manage to be to sustain its healthcare system in this way, technology and health together.
Mr. Bunn, thank you so much for your comments and for assisting us there. Minister, we only have about 3 minutes left, so if I can ask you to respond very briefly before we get closing comments.
No, I wanted to ask, because there's no way we can't be willing if to make a difference. The type of policies and changes which he says are lagging behind. I just want to get an example as a policy maker to understand exactly where we are leaking. I wasn't aware. Yes, absolutely, I'm confessing. I wasn't aware that there's a policy lag that stops us from leapfrogging in other areas, because our own purpose is to leapfrog, and we do understand that we accept that the developed world might have taken 100 years to arrive where they are. And for Africa to arrive there, we don't have the 100 years. We need leapfrogging. We need to jump the steps to use technology. And so there's no problem about that. What I want to understand is where is the lag, where we're not moving fast enough to make it happen.
Minister, we're going to have to leave it there, Mr. But unfortunately, we have to pause it there. But we just need quick closing comments from Mr. Malcolm before we wrap things up. Workable solutions, as you hear, government policy, technology, but I think we also need to start thinking from a regional integration perspective. Tanzania, Kenya, South Africa, we can't be working in isolation.
I think that's right, but at the heart of it all, and I think going to your point, Tony, is people. And we recently did some leadership training with ministries of Ghana, Nigeria, Ethiopia. We asked them if you could have one of three things: unlimited budget, training and education for your teams, or better technology. What would you do to change healthcare in Africa? 77% said training and education. I just couldn't believe it. And when I spoke to them individually to get the in-depth, what they said is, our teams are seeing enormous change, and this technology is extraordinary. Our people don't know how to handle it within the ministry and even in the private sector. So help us drive this change management, this leadership, and then we can implement these wonderful technologies, and we can take healthcare to a whole new level.
Well, one thing for sure is that this conversation will continue to take place, and it's a good thing that all particular stakeholders, government, private sector, NGOs, and others are working together to find a common cause to the sustainability of healthcare development across the continent. Unfortunately, we have run out of time for this special CNBC Africa broadcast, but I'd like to extend a big thank you to all of our panelists and participants in the audience. Dr. Aaron Motsoaledi, who's the Minister of Health in South Africa; Skander Malcolm, President and CEO of GE Healthcare for Eastern and African Growth Regions; Dr. Godfrey Mbaruku, who's the Deputy Director for Ifakara Health Institute in Tanzania; Haddis Taddesse, Country Representative of the Bill and Melinda Gates Foundation in Ethiopia; and Dr. Sarah Barber, who was in our Johannesburg studios, the Country Representative from South Africa for the World Health Organization. And not forgetting the insights that we received in the first half of our conversation from Dr. Nenna Ihebuzor, who is the Director for PHC Systems Development, National Primary Healthcare Development Agency in Nigeria. This conversation will continue offline. You can continue using the hashtag HealthcareInAfrica15, HealthInAfrica15. For myself, Kukule Tutele for CNBC Africa, we'll see you next time.